Well, good morning, everyone. Bonjour à tous. Thank you very much for the kind introduction, Deanne. And thank you, too, to the presentation this morning that gives us the inspiration and the motivation to move on. I'm deeply indebted. But, I, too, would, before I begin, really like to acknowledge that we are on the traditional lands, referred to as Treaty 6 territory, and that the city of Edmonton and all the people here are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canadian First Nations, including Cree, Dene, Stoney Nakoda, Sioux, Saulteaux, and Ojibwe. So I come here today with a couple of hats on. I've had the privilege of working at the palliative education care of the homeless program, as Deanne said. I was a palliative care physician on the streets, in the shelters, in the supportive housing environment. And now as president of the Canadian Medical Association, I think I have a really great opportunity to be able to move this whole movement ahead, to really get a chance to get our politicians to acknowledge and move this forward. But as well, I have an opportunity to maybe change the behavior and the perceptions of the healthcare industry, and that's what I would like to talk about further this morning. And I do make a disclosure, first of all, that I really don't have any conflicts of interest, except that I do receive a stipend as president of the Canadian Medical Association. So the objectives that I'd like to get across this morning, and hopefully at the end of this presentation, they will come through. And again, review the impact of the social determinants of health on health outcomes. I think everybody knows that they're so important, but I'd really like to review the impact. And as a palliative care doctor, I'm dealing with end-of-life issues. I couldn't be more downstream. We really have to deal with the upstream. So the impact that I and my colleagues see every day are really the worst of the downstream issues. I hope to explore the challenges of healthcare delivery for people experiencing homelessness, and there are many. I'll describe some of those common social and ethical complexities that are seen by frontline healthcare providers, and then I'm going to call on health professionals to further engage in improving care for people experiencing homelessness. So like many of you, this is where I work. This is in Toronto. The one on the top left is Seton House. I'm there almost weekly, a 600-bed facility for men with an excellent primary care healthcare program embedded into it by one of our inner-city health associate physicians and teams, as well as a managed alcohol program. But this is what we see. This is where I go and see my patients. Where it says living on the street is hard, dying there is even harder, is a hospice, a residential hospice where the homeless can go at the end of life, called Journey Home Hospice. I'll be talking about that a little later. If you're from Southern Ontario, Toronto, you may recognize this picture, but I think you can guess what it is. The important part about this is the location. This is a heating grate outside the Toronto General Hospital, one of the biggest hospitals, main hospitals in the country. It's just outside the emergency room. The spikes there, of course, are to deter anyone from lying on the grate to warm up. What are we saying by putting those spikes there? I think we're saying to people experiencing homelessness, you don't belong here, and you are not welcome at our hospital. This is an obvious barrier. But what else are we doing in our healthcare system to make people feel unwelcome? What else are we doing to cut off their access? How are we making them feel less stigmatized when they go to emergency rooms? How often are they thrown out of hospital and denied treatment because addict appears on the top of the record that's handed to the physician? For so many patients experiencing homelessness, simply accessing care is a huge challenge. Becoming more aware of the obstacles they face can really open our eyes to the injustices in the system. So what's your stereotype? Many of the reasons people who experience homelessness struggle to receive care because it comes down to these stereotypes. And these stereotypes are incredibly prevalent within the healthcare system amongst doctors, nurses, social workers, etc. What are the staff thinking when someone in the ER, what are the staff in the ER thinking when someone comes in and they might look like this? They look like they're homeless. What assumptions are being made? What do you think? When it comes to approaching homelessness, it is essential that health professionals become more self-aware, really become mindful of what they're thinking when they see these patients come through the door. So we're going to talk about some real people. And these are my patients. This fellow's name has changed, but we have permission. His name is Craig. He's 56 years old. He has pretty severe chronic obstructive lung disease, emphysema, and now is diagnosed with lung cancer. He has a long-standing alcohol addiction, and he is in that managed alcohol program that I referred to earlier. He uses numerous other substances, cannabis and cocaine, but has no history of intravenous drug abuse. But he also has no social supports. He is completely socially isolated. He has a sister in Newfoundland who he hasn't seen in 5 years, so he remains estranged. He's been on the street most of his adult life and has lived in social housing for the past 2 years. I ask you, where can Craig best be cared for at the end of his life? He is a more typical patient than Pandora, and those of you from Toronto or from Inner City Health Associates here will know Pandora. And Pandora gave us complete permission to share her story. She left home at age 15. Father wouldn't let her back into the house after she misbehaved in some way, so she had to go out in the streets to survive. She prostituted herself. Typical story, she became involved in IV drug use. But she developed a disease called infective endocarditis, a very serious infection of her heart valves. And 3 of her heart valves were badly damaged. You would think, we can do this, we can fix this. Surgery, however, was not offered to Pandora. She died in the Journey Home Hospice soon after her admission. If she had had these valves replaced, even if she continued to use drugs, the evidence shows that she would have survived many more years, and I'll refer to this a little later. So what's the real reason she died? Her disease or her circumstances? What role did stigma play? What were the ethical issues here? Would another patient not homeless in the same medical condition be treated differently? So this is a really important slide. What makes us as Canadians sick? You can see in that 50%, number 1 is your income. 2, early childhood development, particularly adverse childhood experiences, now called ACE. More and more information is coming out about that. If you have any disabilities, affects it. Education is right up there. Social safety net, even your gender, female gender in particular. But of course, race, indigenous status, etc. That's what really matters. Even the kind of health care that we're talking about is down here. And your lifestyle, smoking, drinking, that's even further down. Your biology, your genes. We spend so much time and money going into it. Yes, it's important. But in terms of how it affects our health, it's also way below. These are the social determinants of health, and these social determinants are the most important issues that we have to address if we want to improve the health of our vulnerable and marginalized populations. But even more important, if you look, here's a symbol of a tree, and you see the fruits of the tree. So some say neoplastic infectious diseases, that one on the bottom left, that's cancer, other infections, of course. cardiovascular disease, obstetrical complications, etc. Those fruits are the day-to-day things that we as healthcare providers have to deal with. And I'm at the very end. I'm at the end stage of the cardiovascular disease or the diabetes, etc. People are dying. The social determinants are the branches of the tree. So the poor income, low education, unemployment status, homelessness, all the things that we mentioned as the social determinants are really the branches that lead to those fruits. But what we really have to get at to deal with those health inequities of those branches is what's at those roots. And at those roots are where we have to go. Things like imperialism, colonialism, classism, racism, sexism, transphobia. Those are the real roots. And those are the upstream roots. So we can change those branches and change the fruits of this tree. And this gap is real. This slide shows about palliative care patients. Again, I'm looking at it through the lens as a palliative care physician, seeing the downstream effects. And some information that we got from Health Quality Ontario shows that people living in the poorest neighborhoods in Ontario were more likely to have unplanned visits to the emergency department, were way more likely to get admitted to hospital in their last 30 days of life, and were more likely to die in hospital. People don't really want to die in hospital. They don't want to be there. The vast majority of Canadians want to die at home, what they consider their home. So addressing housing insecurity is really about intervening on these health issues upstream, where we have the best opportunity to make a difference in people's lives. Again, my experience is I'm as downstream as you can get. I'm like at the end of the river. But looking at some of the challenges around in palliative care gives me the lens to know what's needed upstream to really make a difference. So in healthcare in this country, a key determinant of access is your postal code. It makes a huge difference. I can be in one area of Toronto, I'll even name it, a wealthy area where I see patients at home called Rosedale, and I can go a kilometer away to Regent Park or some of the others, and the lifespan difference is 15 to 20 years, and it's just a few blocks away. What does that tell us? So as you well know, homelessness is a continuum. It's from extreme poverty and absolutely no shelter to couch surfers, to someone who's suffering from intimate partner violence and income insecurity, who is really precariously housed. They'll never know when they'll really be completely homeless. It's really important to keep this in mind throughout this discussion today, because the vulnerably housed are just as sick as the homeless. So all the health problems we see, it's not just that one person that's living in a shelter, but those 23 others who are also on the continuum of homelessness that are experiencing these health effects. This is a huge problem. And homelessness is heterogeneous. There isn't just one. To stereotype the homeless into, oh, everybody's got mental health problems or everybody has drug problems or both is not right, and it's not fair. Over 30% of people have actually neither alcohol nor drug problems. Yes, there's a large contingent, 40% that have mental health problems, another 30% that have alcohol and drug use problems, and 20% that have both. But it's really important to understand that it's not heterogeneous. So let's not make assumptions about what an individual experiencing homelessness may or not be struggling with. That's a stereotype. But along that continuum, there are serious health consequences. Homeless individuals have a 29 times the risk of the general population, or those that are housed, of hepatitis C. It boggles the mind. 20% have epilepsy, both congenital, but often from acquired brain injury. 5 times more likely to have heart disease, 4 times more likely to have cancer, and in Canada, 1 in 2 Canadians get cancer. 8 times more likely to go to the emergency department. than those that are housed. So the homeless is one of the sickest subpopulations in Canada. So it's not surprising then to see people experiencing homelessness at the highest mortality rates of any population in Canada, 2.3 to 4 times greater than the general population. So I show here the life expectancy on the streets. It's between 34 and 47 years old. So let's say 40 years old for short. Well, the average Canadian, men and women now, live to 82. And where are these people at the end of life? They're in emergency departments and acute hospitals. The majority go there, but sometimes in transitional spaces or shelter settings. Like 90% of Canadians, the homeless want to die at home. They want to die where they feel comfortable and maybe cared for. It's just what they call home is different. But our system doesn't make it possible for this population. And most die in hospital, again, park benches, literally on the street. It's an early death sentence, it's in our own backyard. And can you tell me any disease that can reduce mortality by 50%? There isn't one. This is an issue of life and death. And we're seeing people like Skelly Stajuhar of Victoria, who's now studying it. And what we're finding out, yeah, we're getting some palliative care to this population, but well, it's way too little and it's way too late. And it's when they're homeless and vulnerable because of programs like we're developing to provide dignified and comfort care at the end of life, why we're not doing upstream. So we're making some gains at the end of life. But what about everything so much earlier? Too little, too late. I want to bring us back to Pandora because like all of you, you know people on the streets who are suffering here. So recall she died of infective endocarditis, infected heart valves, of which she had 3. And I had to wonder, as I was doing her pronouncement in the hospice, why wasn't she given the chance for surgery? She was only 23 years old. Would she have wasted the resources that it takes to save a life? Because that's often what's said. Is a history of certain behaviors, such as substance use, an ethically defensible reason to restrict a patient's repeated access to potentially life-saving healthcare resource? Disqualifying Pandora from accessing a medically indicated healthcare resource based on her substance use intensifies her structural disadvantage and leaves her worse off. Here's a study done by Wayman here for people with IV drug use who had surgical treatment for infective endocarditis. Look at the survival rates. 1 year, 90% survived, and even at 10 years, 85% were still alive, and those were people that had repeated substance use. None of the subjects in these studies required a second operation. A harm reduction approach could really address the situation. Abstinence might be too high a bar, but it's possible to use in a safer manner. Teach safer injecting, offer sterile supplies, and use in a safe injection site. Refer to social supports, primary care, and possibly addiction treatment if she was ready for it. We could have given Pandora a chance, in my opinion. Many of you might know Nahid Dasani. Nahid's a young palliative care physician in Toronto who started our PEACH program the day he finished his residency training back in about 2013. And this is what he tweeted one night. We mourn another death in hashtag Toronto shelter system tonight. Cause of death, hashtag poverty. Rest in peace, my friend. So this really captures to me in a nutshell what we're talking about. Poverty kills. I'd like to tell you too about Marie. Marie was one of my patients at an older hospice that we had in Toronto that unfortunately no longer exists. It's called Parham House. And Marie was a 42-year-old woman who had 2 children, age 8 and 12. She was a single mom. She had about a grade 8 education, and she was a devoted mom. She was unemployed for quite some time when she was raising them alone. And she was on the continuum of homelessness, occasionally often couch surfing, staying with people she knew. She would get health care for her kids, but she never got it for herself. She was too busy, and I suspect she had a traumatic history. She died of cancer of the cervix. She never had a pap smear, an easily obtained test, and a cancer that is 100% preventable. And as I was leaving the hospice after her pronouncement, I thought to myself, why couldn't I write down poverty as a cause of death? This is what Deanne was referring to earlier. Why couldn't I do that? Why do death certificates require only biological causes? I had to write down cancer of the cervix, metastatic, that it had spread. But it was really the poverty that killed her. It was her dedication to her kids and her life that prevented her from getting the kind of health care she needs. It was probably a matter of some health literacy as well. We get a lot of our information from death certificates, and unless we get it on the death certificate, we can't really keep the right kind of data to make a difference for government, and this requires legal change. So this I highlight because it's yet another barrier at the real issues at play in our societies, hindering the ability to gather information that accounts for the real impact of the social determinants of health. Now, this might seem like a no-brainer, right? Homeless deaths preventable with homes. Big report. But it isn't always so straightforward. So take opioid deaths, for example. People who use drugs are actually more likely to die if they're using at home alone rather than on the streets surrounded by others. There was a recent report from here in Alberta that showed that 75% of people that died from an overdose in 2017 actually had a permanent address. And over 60% died in their own home without others nearby, who could intervene and call for help. It's all about stigma. Stigma surrounding drug use contributes to the fact that many people use alone. So I'd like to focus briefly on structural vulnerability. Dr. Stajuhar, I mentioned earlier, and other palliative care researchers at the University of Victoria have taken this term structural vulnerability as a useful description for us to use as a community. It really captures the vulnerability of the people we see every day, which is produced by their location within a hierarchical social order of diverse networks and power relations. People who are impacted by social and structural inequities are known to be at heightened risk for poor health outcomes, of course, inadequate access to health services, and early or premature death. We're talking about socially and structurally excluded people who get sicker because of structural vulnerability by diabetes, cardiovascular disease, cancers, HIV/AIDS, Hep C, which is often then coupled with a serious mental illness or substance use. In Canada, in this day, some places you simply cannot see a doctor without an address. It's a prerequisite for a health insurance card. Other example shows that there's palpable discrimination among health providers on the grounds of HIV or hepatitis C status, and also, of course, on racial background and substance use. You know, it's very hard for individuals, teams, and organizations to really think about the ways that we may discriminate. Most people believe they don't have these kind of biases, and everybody is getting gold standard health care. But we are part of the system that create inequities for patients. We, as healthcare providers, are implicated in these discussions. This leads to further barriers for access. And so we talk about double vulnerability, or the intersectionality of health and social factors. When I originally went into palliative care, I knew I had that sense of compassion and disease for people who were vulnerable. And in hospice and palliative care, every patient who is facing a life-limiting illness and potential death is vulnerable Doesn't matter what your socioeconomic status is. People are suffering. But equity-informed research has demonstrated that palliative care, my discipline, really tends to discount the needs of those who could be characterized as doubly vulnerable, being that they're both in need of palliative care services and experiencing deficits in the social determinants of health. And as a consequence, they live with complex intersecting health and social concerns. I'll give another example in real life that hospice and palliative care providers often make in the community, and our government and our system does. Okay? We assume that people have caregivers, that their caregivers are capable of giving care, and that they have a roof over their head, and that they have income to supplement their caregivers and themselves as they approach the end of life. When I'm delivering the care in Rosedale and I see the resources that are given to people who are truly suffering, I know it can be done. And I know it can be done for this population. So I see death as a social justice issue. Inequities seen during life accumulate at the end of life. Bottom line, people die like they live. We have all seen that. So this is truly a matter of human rights. And the UN Universal Declaration of Human Rights states that everyone has the right to a standard of living adequate for the health and well-being of themselves and of their family, including food, clothing, housing, medical care, and necessary social services. So as a healthcare provider, I often ask myself, what is my specific accountability here? Who am I accountable to? In other words, what is my social contract and duty to those in need of housing? Some of you, especially if you're from Saskatchewan, may know Dr. Ryan Miley, family doctor out of Saskatoon. I met Ryan many, many years ago when he first got out, and he was the upstream guy. If you haven't seen it, go to upstream.ca. He is now the leader of the New Democratic Party in Saskatchewan, and he would state, a socially accountable health system is one that dedicates resources to where they are truly needed, up and downstream. So this raises some important questions. At the local level, how socially accountable are physicians and other healthcare providers to their patient population? What are their organization's priorities to serve all members of the community? Do they target services, funding, and resources in a way that reflect the vulnerabilities of the population where you live? What are their clinics, hospitals, and professional organizations doing to address these issues to be accountable? Taking into account the social gradient and determinants of health, how accountable are they really being to the lives and plight of all who live in this country? Or are they putting up barriers like on the grate in front of Toronto General Hospital? Whoops, there you go. Okay. So there was support by the Canadian Medical Association for support for a national housing strategy. Hang on a minute, I'm just a little off the way here. I was approached by Andrew Bond, Dr. Andrew Bond, of my medical director at Inner City Health Associates in Toronto, and by Tim Richter, to get the Canadian Medical Association's support behind a national housing strategy. Having our kind of good housekeeping seal of approval on the letter to the government actually supported this, and this is now legislation, I believe, since June. This is one of the ways the Canadian Medical Association can help. And at the CMA, we want to do continued advocacy. So there's many things that we're hoping to do. We're continuing to apply pressure. We're going to follow through now that we have the new government for the right to housing, that it remains a priority for this government. We're a member, the Canadian Medical Association, a member of the Canadian Coalition for Public Health in the 21st Century. And most recently, we're involved in the development of the Common Election Platform, which included the need to address housing and homelessness as a social determinant of health. So we're going to call on the federal government to deliver on the promises outlined in the National Housing Strategy and to invest in the strategy and programs to support Canadians of all economic and social backgrounds. We're also endorsing evidence based on clinical guidelines for the homeless, vulnerably housed, and people with lived homeless experience. At the CMA, our mission is actually empowering and caring for patients, and like we heard this morning from the elder who was here, we need to walk the talk. That means giving patients a seat at the table when considering improvements to our healthcare system. We've created a new patient engagement body, the CMA Patient Voice, that brings together 12 patients from across the country to advise on and inform our work. So we're going to integrate this important perspective more and more into our work. It's so important that we partner with patients and people who can. So about 7-8 years ago, as president of the College of Family Physicians, we developed this social accountability working group, and we got people with lived street experience on our committee. Everybody else was volunteer. We paid them. We supplied them with cell phones, computers, so that they had the equitable, they were given that extra lift to be able to participate in a committee like this. And it was so important to really have their voice at the table. And at the CMA, we're going to continue that, the patient voice that gives us insight into the social determinants of health. And there's so many things that are best practice now that we can do in homeless health. So one of those key principles being outreach. You have to go to meet people where they are. We can do intensive case management, checking in on our patients frequently and making sure their needs are being met. The care has to be interdisciplinary, interprofessional. No one can do it alone. Doctors can't do it alone. Nurses can't do it alone. We have to do it together. We'll bring in addictions, mental health care workers as needed, and we have to provide care across settings. So the PEACH program I mentioned earlier from Inner City Health Associates in Toronto, I'm just so proud to be involved in that. Our goals with this program are to meet the needs of people who are homeless and vulnerably housed wherever they are, so we go where they're at. We go into the streets, we go into the shelters, and we give the actual care wherever they are. It's not a doctor-driven enterprise. We recognize the need to think and work in terms of team. But we've had some good outcomes. This is just a brief slide showing some of the diseases that we do deal with. The orange parts are kind of cancer and COPD. The green is end-stage liver disease, and some of the other things that we deal with here. The usual, but way more common in the homeless population. And looking at some of our outcomes that we've assessed, 64% of our patients while under our care did not have to go to an emergency department or need any hospitalization. And these are people with multiple illnesses and serious life-limiting illnesses. 80% were able to end their lives in the location of their choice. 83% were reconnected at this stage of life from family and friends from whom they were estranged. In terms of opioid use, almost 60% of patients had a prescription and 90% had substance use assessments. And finally, 83% were treated in this shared care model with a range of health professionals sharing a joint responsibility for this care. And working together, the PEACH program, St. Elizabeth Healthcare, a national nursing healthcare organization, Hospice Toronto, and Inner City Health Associates, we created, I believe in early 2018, Journey Home Hospice. And it's a great example of what actually can be done for the homeless community. And the work is guided by a community advisory panel, including people with the lived experience of homelessness, like I mentioned earlier, and a dedicated team of leaders, physicians, other health professionals, staff, and volunteers who each bring a unique perspective and expertise to the team. They measure quality, patient safety, patient satisfaction, and system impact to ensure they're achieving their goal of excellence in homeless and end-of-life care. And you know what's happening, kind of ironic, the people that are coming into the hospice with very severe life-limiting illnesses are living longer, much longer than expected. They have a roof over their head. They're getting 3 square meals a day. They're getting incredible attention and love and care, and they thrive despite their serious illnesses. It's quite remarkable. So I'm going to conclude with sort of the 10 top tips, the promising practices that we can give as healthcare providers for people experiencing homelessness. What can we do now? And I'm not only going to talk about kind of what we can do individually, but what can we support at the national level through the Canadian Medical Association and other organizations. So let's get equity by designing for it. People have seen this, you've all seen these kind of images before. So in that first image on the left, it's assumed that everyone will benefit from the same supports. All the kids are treated equally. The tall one who can see the game, the middle one who can just see the game, and of course the little guy who can't. But they're all treated equally. In the second, we've done the equity approach. You know, we've moved that soapbox from the tall kid to the little one, and now all can see the game. So we've made some improvement. But in the third image, all three can see the game without any supports or accommodations at all. Soapboxes are removed because the reason of the inequity was addressed. The systemic barrier to access was removed. So let's remove those barriers when it comes to accessing health care for our populations experiencing homelessness. Whether it's that sidewalk grade outside the Toronto General Hospital, whether it's looking at pharmacare and access to medicines, harm reduction approaches incorporated into all levels of care, or better intersectoral collaboration between health and social sectors. We need to screen in every primary care medical practice for the social determinants of health. And what you're seeing here is a new tool that was developed actually as well at St. Michael's Hospital in Toronto by Dr. Gary Block and colleagues, and has now been upscaled right across the country. We have to screen for those social determinants of health, especially poverty, in our practices. Simple question: do you ever have difficulty making ends meet at the end of the month? It's sometimes sufficient. Its sensitivity is 98%, and it'll specifically identify 60% of those who are living below the poverty line. So just as we screen for smoking or diabetes, we need to screen for poverty with the goal of improving patients' health. But it's unethical to screen for something unless you can do something about it. I was working in Malawi in Africa, and I actually counseled against pap smear screening there because there was no treatment for people. We could tell women that they had cancer of the cervix, and there was nothing that we could do about it. So we can't screen for something unless we can do about it. But we can do a lot here. We can address the social determinants of health. I sort of think of system change at micro, meso, and macro levels. Micro for the individual, meso for the community, and macro at the system. So at the micro level here, with each and every patient we see, we can raise awareness about tax credits and extra income supplements and can assist with disability applications, for instance. That improves their income. At the meso level, we can lend our support to programs making a difference in the communities. So I've been fortunate to be able to do that through Peach, or the Journey Home Hospice. So you become aware of many of the services that could be better supported by health professionals in the healthcare system. But at the macro level, we can advocate on behalf of our patients for a basic income guarantee, the National Housing Strategy, and other critical initiatives that address the social determinants. Number 4 here is key. It's better integrating social and health services so that we can better provide care to our patients with complex needs. There are many social services that need more support from healthcare providers in the healthcare system, and the reverse is also true. It's important for organizations to commit to addressing people's needs more holistically by establishing these formal linkages, by establishing clear lines of communication, by establishing those important referral relationships. We need digital infrastructure to support sharing data as well. And we need always interprofessional teams. Number 5, adopt these harm reduction approaches. They involve a range of health and social services to better support our patients and create safer and healthier communities. Harm reduction is not restricted for people who use drugs. Its approach should be adopted routinely, in my opinion, in every health and social program. A harm reduction approach seeks to reduce the adverse health, social, and economic consequences of something without requiring that practice to stop. In other words, again, meeting people where they're at. Seatbelts, when you drive a motor vehicle, is a harm reduction approach. It can still cause the accident, but you won't be injured or killed as severely. In the case of psychoactive substances, we see patients without requiring abstinence. In our hospice, people use. The Journey Home Hospice was a safe consumption site. It's about reducing the number of barriers to care. And I've said this several times already today, and I emphasize it now as number 6, meet people where they are. Recognize that the barriers, and particularly stigma, that people experiencing homelessness face when trying to access emergency departments and hospitals. Meet people where they at, whatever they call home. Walk alongside them, build trust, address the needs that people identify as important for themselves, not to focus on the ones that we care about, the ones that they care about. Number 7, prioritize their dignity. Prioritize client dignity in the context of their trauma histories. Do not make assumptions about anyone's background or past experiences. Do not make assumptions about their background or past experiences. Recall those stereotypes. Think about your own stereotypes. In the end, it's all about relationship-centered care and what's happening between you and your client, me and my patient. It's building those trusting connections between the patient and provider. We have to enhance trust, and that provides dignity. You know, it's really interesting at the end of life that many of the people we see have their chosen street family. So we do advanced care planning, goals of care planning. We ask them to name a substitute decision maker in case they're unable to make decisions for themselves if they lose capacity. And they often choose a peer, a friend, someone in the shelter or on the street. And some people, I can see their eyes rolling about what kind of judgment will this person have for them. But it's not so. We got to give them a chance. We got to get around that traditional thinking of family. We got to recognize, foster, and respect those who our clients and patients choose to involve in healthcare decisions, and do not be judgmental. In addition, some of the people take the care of the sick person on. They become the family. They feel really good about contributing and having some purpose in their own lives. It's amazing to see. So this is called inclusion health, and this should be at the core of medical and, might I add, any other type of medications. So let's be more inclusive. So specific to palliative care, social service staff can learn more about the approaches that we apply. And on the flip side, healthcare providers need to learn more about the context, experiences, and specialized needs of people experiencing homelessness and living in poverty. And finally, let's employ those holistic models of care. So we're addressing the physical, the psychological, emotional, social, and spiritual needs. For example, through Inner City Health Associates, who runs this, we have something called the Good Wishes Project, and it provides people experiencing homelessness with 3 simple wishes to ease their end of life. We get requests like a special meal with friends, a visit by an out-of-town family member, or even tickets to the theater, a dinner at the Keg. The goal is to go beyond their physical needs and ensure they have comfort and dignity in their final days. We all want to, and we all need to see change. When it comes to making that change, I, along with the Canadian Medical Association, are here as your healthcare partner. And I call on all health professionals across the country to join us in improving care for people experiencing homelessness. I'd like to extend particular gratitude to the Canadian Alliance to End Homelessness and all the organizers of this critically important conference. Thank you to all the participants here for your efforts in addressing the needs of those so vulnerable in our society. Thank you to all the speakers and attendees. Thank you to our Indigenous brethren for your support and your guidance and wisdom. And thank you for inviting me today. Working together, we can affect the change in our healthcare system needs and our fellow human beings deserve. Thank you. Merci. Miigwech.